Thank you. And we have just over 5 minutes left for questions. If you do have any questions that you want us to address, if you can just come bring them down to the front or wave them in the air and someone can collect them, that might be the best way. Are you able to move to collect? Okay, keep them up. We actually do have a couple of questions. Jan, maybe you could start off.
Okay, yes, I have a question about from a colleague from Egypt, and he says, well, I see many times secondary ADHD which is characterized by the same symptoms, same core symptoms as defined in DSM-4, and then when I treat the original primary cause, I can alleviate the problem and I don't need any specific drug treatment. And basically he suggests then, should we add this subtype? I think the problem is that when we think about causality in general, all our data are group data. So all data about genetics and gene environment issues are group data, suggesting that on average genetic factors are very important and that environmental factors are complementary to that. But it's very difficult in an individual case to pinpoint to specific causes, particularly because you cannot tease apart the contribution of the environment and the contribution of the genes. So, for example, the slide I did show to you about adversity and the genotype risks, you may think it's all due to environmental adversity, but the genotype may be important as well. Second, our diagnostic system, the DSM-4, is descriptive. So if the child has the symptoms, you should just say this is ADHD, and if there is a child within very severe environmental problems, of course family approaches, alleviating the environmental problems is okay. In my experience, that very rarely leads to alleviate all symptoms. It's then part of the total treatment approach. So that's my main comment on this question.
Yes, I've got a question here from a Mrs. Hayes, I think it is, from Switzerland. And the question is, I'd like to learn more about pupil-parent partnerships. An example of such activity would be interesting. Now, I'll pass over also to my two colleagues here to help answer this question as well. But just to start with, in my presentation I made reference to nurture groups, and one of the unexpected effects of a nurture group would appear to be that as a result of the improvements that the students themselves experience in schools, interviews with parents have revealed that this seems to have a knock-on effect to the quality of parent-child relationships in the family situation. And it's a bit like, I think, what Andrea was referring to earlier when she talked about the effect of medication and how the improvements in the child in turn can have this sort of halo effect in the family, possibly due to the fact that the child becomes more congenial to deal with, and this tends to lead to improvements in relationship. So the nurture group would be one example of an intervention which actually helps to improve the quality of child-parent interaction, partly as a result of the fact that it improves the quality of interaction between the parent and the school as well. But I'll also pass on to Andrea and Miriam to answer, offer something on that.
Well, we have a lot of things going on, participating parents, schools and all that. Maybe it would be easier to come to us afterwards and we have a talk. Especially I think there are some major differences between the German approach and the English approach.
Shall I go on to this next question here? This is a question here, sorry, from a lady in Switzerland, or I don't know, it's a Dr. Lou. Do you have any experience with ADHD patients in sports? If yes, what influence do the medications have to the sports? Is that a question? It's an interesting one because there's different kinds of sports that children with ADHD like. I mean, a lot of children with ADHD find sport very difficult. Some children with ADHD actually excel in sport. I think football is an area where they excel a lot. We've spoken to children who play football, who play tennis, and it's interesting. Some of the children who play football find that they play a better game without medication. Some say they play a better game with medication. So I think it's really down to the individual children. And I recently spoke to a young boy who's 12 years old who just recently started taking medication. And he plays tennis. And I asked him what difference it made. And he said, before I took medication, I would just hit the ball anywhere and it might go in and might go out. Since taking medication, it's almost like the game has slowed down and I can see the ball coming towards me and I can hit the ball and place it and my game has improved.
And another example is judo, and if there is a partner also ADHD, they can do it without medication because, you know, they do it kind of a different way. They have to talk about it, and sometimes they have problems with the trainers because they think they're behaving odd and not fitting in, but I think we could talk about that for hours. There's a wide range, and it's a good thing for them to do sports anyhow because they need exercise and getting tired.
I have a couple of questions that I'll just do quite quickly. First is about long-term effects. Someone asking when we'll have data past 2 years. Well, we're never going to get data from randomized controlled trials for more than 2 years because many places, in fact everywhere, I think most of us would agree, it's unethical to withhold treatment, which is what you would have to do by giving placebo for that length of time. However, the follow-up data for the extended release stimulant medications, particularly the data for Concerta and also data for atomoxetine, are now becoming much more available. I think for Concerta we've had 5-year data presented from Tim Willins to Tim's. Yeah, growth data. I mean, most of the data is safety data that we're looking at for the long terms. So I think we have a lot more to do there, but data's starting to emerge. A question that I'm not going to answer directly, but I think is important. What is the difference of pharmacological mechanism between stimulants and atomoxetine? Well, that's a question I'll say go away and find the answer, but actually everyone ought to think about that and know that yes, there are differences, and not only between atomoxetine and methylphenidate, but also between methylphenidate and the amphetamines. And that's why different people respond in different ways, and also some of the effects of the drugs may be different. And lastly, in this group, we're not going to be able to get through all of the questions. What about combination medication? Is there any place for a combination of immediate release and extended release, or of methylphenidate and atomoxetine? Immediate release and extended release, in my clinic, and one of the reasons I showed you those charts, is that we found that if you think about what the timescale of effect that you require is, then the only time we find that we ever have to actually add an immediate release to an extended release is at 4 o'clock in the afternoon if we want to change an 8-hour medicine into a 12-hour medicine. Others suggest that, we quite often need to add medication, an extra dose of medication, immediate release in the morning to the extended release. Well, our answer to that has been to try to titrate to the right dose of extended release, and remembering that you sometimes need to give more than you think, or looking at the different combinations of immediate release, extended release balance. So in my experience, it's that you only have to do that very, very rarely. Others will do it more often, but I stick with what I say. And atomoxetine and methylphenidate together, we don't have the data. Probably there'll be children who will benefit from that, but I want to see more in the safety data. I want to see more in the effectiveness data. That's us at 6 o'clock. There is another lecture at 6 o'clock, so we need to finish. Thank you very much indeed. Sorry, just as a consequence, because there's another lecture at 6 o'clock, we won't be able to stay and answer questions here because we need to get out of the room.